coarctation of aorta, to discuss endocardial cushion defect, to discuss patent ductus arteriosus. يعني راح نكمل acyanotic congenital heart diseases, obstructive والendocardial cushion defect في الPDA. Endocardial cushion defect. Endocardial cushion defect. The other names of this disease is arterioventricular septal defect, or it is called AV canal defect. Normally, during embryonic life, there is a tissue located here. It's called endocardial cushion tissue. During embryonic life and the development of the heart, this endocardial cushion tissue is responsible for the development of the inlet part and membranous septum, also the septum primum of the interarterial septum, because the interarterial septum consists of part comes from up called septum secundum, and part grows from the endocardial cushion tissue up called septum primum. So the endocardial cushion tissue is responsible for this development of the septum primum, and part of the ventricular septum, which is the inlet and the membranous septum. At the same time, it is responsible for the development of the septal leaflet of tricuspid valve and anterior leaflet of the mitral valve, which is located here. There is some problem with this endocardial cushion tissue, which is located here, in the heart of the heart. If it is there is some problem with this tissue development, any one of these parts may be abnormal. So the patient may develop ASD primum, and in this case it is called incomplete or partial AV canal, or partial endocardial cushion defect, or partial arterioventricular septal defect. So it is incomplete AV canal if it is only the septum primum involved. If the septum primum and the inlet interventricular septum are involved, so this is called complete endocardial cushion defect, or complete AV canal, or arterioventricular septal defect. So partial is only septum primum, ASD primum, and complete ASD primum plus delayed VSD. In addition, in the case of complete AV canal or endocardial cushion defect, there is some cleft in the septal leaflet of the mitral valve, and there might be cleft in the septal leaflet of tricuspid valve. So this is the endocardial cushion defect and why it develops. Clinical manifestations: because of the large mixing of blood at both arterial and ventricular levels, in the case of complete AV canal, the patient develops features of heart failure as early as the age of 6 to 8 weeks. Usually the growth is poor, and large percentage of children are Down syndrome patients, because Down syndrome patients have high incidence of congenital heart disease, and 50% of the congenital heart diseases in Down syndrome children are in the form of endocardial cushion defect, complete endocardial cushion defect. And because of the large mixing of blood at arterial and ventricular level and shunting of large amount of blood, the patient may develop early pulmonary hypertension and early pulmonary vascular resistance. And the main characteristic of pulmonary hypertension on examination is loud second heart sound. So loud second heart sound is a very powerful indicator of pulmonary hypertension. When you auscultate a patient and you find loud second heart sound, this is a good proof that this patient has endocardial, that the patient has hypertension, pulmonary hypertension. By investigations, the ECG of the patient may show left axis deviation by ventricular hypertrophy. and biatrial enlargement. By time you know what is left axis deviation, ventricular hypertrophy, because I discussed it in the last lecture. By chest X-ray, there might be cardiomegaly and increased pulmonary vascular markings, the same as with ASD and PSD. And by echocardiography, you can see here, there is arterial septal defect, but it's not located in the center like ASD scandal. It's located here, close to the AV valves, that is to say, ASD primer, and also there is VSD if you see here. And when the valves open, you see that there is a continuous defect involving the interarterial septum and ventricular septum. This is the endocardial cushion defect, and this is the mixing of blood at both arterial and ventricular levels. Also, the echo will give you idea about the cardiomegaly, about the heart failure, and about the valves and the presence of other problems. واضح الصوت والصورة يا شباب ويا شابات؟ ما في إشكال يعني. ايش قد عدد الحضور حاليا؟ 26. نعم. لأن ما تطلع عندي من أعمل سلايد شو ما تطلع عندي يعني عدد الحضور. بس هذا البرنامج الجوجل ميت اتندنت هسجلكم واحد واحد، هيسجل يمتى يدخل يمتى يطلع من المحاضرة. تعرفون انتم الجوجل ميت اتندنت. تريتمنت باختصار بكلمتين. treatment of heart failure and surgical repair. راح نجي بعدين احنا على treatment of heart failure. Surgical repair involves surgical closure of ISD primer مثل ما شوفناكم بالISD. The surgical closure of the VSD, which is usually earlier type of VSD, and the repair of the valves if they are involved. Usually, it is done after the age of 6 months, between 6 months and 1 year, because the patient yearly develop pulmonary hypertension and pulmonary vascular disease, as we said in the clinical demonstrations. The second topic is patent ductus arteriosus. You remember in the first lecture we said the ductus arteriosus during the fetal life plays an important role in shunting the pulmonary blood into the descending aorta because there is no pulmonary blood flow and there is high pulmonary vascular resistance. After birth, when the pulmonary vascular resistance falls and the pulmonary blood flow starts, there is no need for the ductus and will close spontaneously during the first few days of life. In some cases, it will not close, and here it is called patent ductus arteriosus. You know, after birth, the aortic pressure is higher than the pulmonary pressure, and in this case, the blood will be shunted from the aorta into the pulmonary artery. In the fetal life, it was the opposite. The pulmonary vascular resistance and the pulmonary pressure were high compared with the aorta, and the blood were shunted from pulmonary to aorta. After birth, the opposite happens and the blood will be shunted from the aorta into the pulmonary arteries. Anatomically speaking, the proximal end or the aortic end of the ductus is located just opposite to the origin of the left subclavian artery. Here. And the pulmonary end of the ductus arteriosus is located just at the bifurcation of the pulmonary arteries. Epidemiologically speaking, it is more common in females than in males in a ratio of 2 to 1. The same as the ISD. So ISD is more common and PDA are more common in females than in males. It might be associated with the prematurity. There is high incidence of PDA in premature babies because the muscular layer of the walls of the ductus arteriosus and the premature babies is not well developed because they born prematurely and they are not responsive to the constrictive effect of the oxygen like in the full-term babies. For two reasons. Number one, the muscular layer not well developed like in full-term babies. Number two, they are not well responsive to oxygen, which causes constriction of the ductus arteriosus after birth, making it having higher incidence in the premature babies than in full-term babies. In fact, PDA makes 10% of all congenital heart disease. And usually, in most of the cases, as I said, it transmits blood from the aorta to the pulmonary arteries and might be harmful. In few cases or some cases, it is useful. The PDA is useful. Where? Number one, if there is critical pulmonary stenosis or pulmonary atresia, so that there is no pulmonary blood flow. And here, the ductus is of critical importance because it will be the only way to provide the blood to the pulmonary circulation, which is mixed, of course. There might be VSD, mixing the blood, so the aorta receives mixed blood, oxygenated, deoxygenated, and through the ductus it will go to the pulmonary if there is pulmonary atresia or critical stenosis. So here it is useful and should not be closed. In the other case, like in the critical or severe coarctation of the aorta, when the distal end of the aortic arch is very stenosed or closed, the ductus also plays an important role in providing blood from the pulmonary to the descending aorta and to the lower part of the body. There must be also some VSD mixing of blood here, or ISD making mixing of blood, so that the lower part of the body receives mixed blood. Otherwise, this is incompatible. So, ductus, almost it is harmful. Rarely it is useful in the case of pulmonary atresia to give blood to the pulmonary circulation, or in the case of interrupted aortic arch or severe coarctation when it gives the blood to the lower part of the body. In fact, the pathophysiology of PDA is more or less similar to the VSD. The clinical representation the same, the investigation findings are also the same. As I said, because the pressure in the aorta is higher than that in the pulmonary, in both systole and diastole, so there will be run of blood from the aorta to the pulmonary artery during both systolic and diastolic phase. If it is small, the PDA is small. To tell you what is the small, what is the large, just take it like that. If it is a small PDA, the effect is limited and the patient might be totally asymptomatic. If it is large PDA, the amount of blood which is going to be shunted from the aorta to the pulmonary artery during systole and diastole will be high, and the patient will be at very high risk of the development of pulmonary vascular disease and pulmonary hypertension if left unoperated or unclosed. Why? Because the pressure in the aorta is very high compared with the pulmonary artery pressure. So there will be pulmonary hypertension. There is what we call it high pulse pressure in the patient. Pulse pressure means systolic pressure minus diastolic pressure. Normally when you measure the blood pressure of the patient by the cuff from his arm, let us to speak about the adult to make it easy to understand. During systole, the blood pressure will be 120 normally. During diastole, it drops to 80. Why it doesn't drop to 0? Because during diastole, the aortic valve closes, the blood will not return to the left ventricle, remains in the aorta, and the pressure will not drop to 0, rather it drops to 80. The pulse pressure normally is 120 minus 80, which is equal to 40 millimeter mercury. If there is ductus arteriosus and it is patent. During systole, the blood pressure also will be 120 if you are speaking about the adult. During diastole, the blood will also flows from the aorta to the pulmonary artery. So the pressure in the aorta drops below 80 because part of the blood is escaping from the aorta to the pulmonary. And instead of being 80, it will be, for example, 50 or 40. So if it is 60, for example, 120 minus 60, it will be 60. So the pulse pressure is wide compared with the normal pulse pressure. Why? Because of run of blood into the pulmonary artery during diastole. Of course, the blood pressure in the pediatric patients is less than the adult, but I am saying these figures of 120, 80, and the adult because you know it and to make it easily understandable. Symptoms. مثل ما قلنا ال PDA more or less similar to the VSD. If it is small, it is asymptomatic. If it is large, the patient may develop features of congestive heart failure and later on features of pulmonary vascular disease. On examination, مثل ما قلنا, wide pulse pressure, thrill may be felt here with hyperdynamic precordium. If you put your hand on the precordium, you feel that the heart is hyperdynamic, beating excessively, and the thrill may be palpable here. The characteristic murmur of patent ductus arteriosus is a continuous machine-like murmur. Can be heard in the left infraclavicular area, which is the area of the ductus arteriosus. When I say continuous, it means systolic and diastolic. Why? Because the blood flows from the aorta into the PDA during both systole and early diastole. Because the pressure in the aorta is higher than in the pulmonary during systole and diastole, and the blood will flow during systole and diastole, and you will hear murmur during systole and diastole, which is called continuous machine-like murmur. And also can be heard over the left part of the back because the PDA is somewhat located posteriorly. Chest X-ray, ECG findings similar to VSD. Small VSD and the small PDA have the same features. Large PDA, large VSD have the same features on ECG and chest X-ray. By echo, we can see the PDA. This is the aortic arch, and you can see the PDA. And by color flow, we can see the blood flowing through the PDA. And differential diagnosis of PDA, anything which causes continuity between arterial and venous, between aortic and pulmonary systems, may give a murmur similar to that of PDA. For example, we have a defect called aortopulmonary window defect. You see, it is located here just at the origin of the aorta and the pulmonary artery, and same like the PDA, there is mixing of blood between the aorta and the pulmonary artery, and you will hear a continuous machine murmur. The same if you have arteriovenous fistula, if you have in truncus arteriosus, you got only single vessel arising from the heart. There must be VSD, and there is a single vessel arising from the heart, and this vessel then divides into pulmonary and aortic. This is called truncus arteriosus, and because of the mixing that happens here, it gives murmur similar to PDA. So the differential diagnosis, as you see, aorto-pulmonary window, truncus arteriosus, arteriovenous fistula, and even VSD with aortic regurgitation can give you systolic and diastolic murmurs, which are similar to PDA. Naturalist, what happens to the patient with PDA if left untreated? In full-term infants, there is no chance of a spontaneous closure of the PDA. But in the prematures, it is possible. Of course, for small PDA, not large PDA. Heart failure, pneumonia, they can develop if the shunt is large. Pulmonary vascular obstructive disease, pulmonary hypertension can develop with large PDA, like VSD. Rarely, there might be aneurysmal dilatation of the PDA in the adult, and even rupture. And this is a rare complication. Treatment. All PDAs should be closed when the age of the patient is suitable, either by coil, which is like that, if it is by transcatheter method. Let us to say there are two ways of closure, either by surgical ligation or by transcatheter method. Surgical ligation is the job of the cardiac surgeon. Transcatheter method is the job of the pediatric cardiologist. By transcatheter method can be closed either by coil or by occluder device. The shape of the occluder device may be like that. Or we can get another shape. But this is the commonest type of the occluder devices of the PDA. Either coil for the small PDA or occluder device like this one. For example, in the case of coil, the catheter is introduced from inferior vena cava, right atrium, right ventricle, RVOT, pulmonary artery, ductus, aorta, and then we leave the coil inside the ductus. For the occluder device, the same, and we leave it in the ductus arteriosus. Or the surgical ligation like that. This is the job of the cardiac surgeon. This is the job of the pediatric cardiologist. Coarctation of the aorta. As an example of the obstructive lesions, which are three in number, as I told you, coarctation, aortic stenosis, pulmonary stenosis. These are the second subgroup of acyanotic congenital heart disease. Acyanotic congenital heart disease. Those which are left to right shunt, now finished, and we are going to the obstructive lesions. صوت واضح والصورة واضحة يا شباب؟ Okay. For the obstructive lesions, we'll start with the coarctation of aorta. By definition, it is constriction of the aorta distal to the origin of the left subclavian artery and ductus arteriosus. تذكرون قلنا aortic end of the ductus arteriosus just opposite to the left subclavian artery. Coarctation is constriction of the aorta distal to the origin of the left subclavian artery and ductus. And it is said that during embryonic life and the development of the aortic arch, the area which is near the insertion of the ductus arteriosus fails to develop normally, make it narrowing than the normal. And this lesion, coarctation of the aorta, makes 5 to 10% of all congenital heart defects. Clinically, the clinical manifestations depend on the severity of the narrowing. The more the severe the narrowing, the earlier the presentation, the more the severe the symptoms, and vice versa. The less the severity of the narrowing, the later the presentation, the less the severity of the symptoms. We divide the patient into two groups. those who develop symptoms in infancy, and it develops in the form of feeding difficulties, respiratory problems, and even they may develop shock if there is critical coarctation and hypoplastic aortic arch, which is usually associated with VSD. So, an infantile type of coarctation, infants have poor feeding, respiratory distress, shock, and may have hypoplastic aortic arch with VSD. Those who pass the infancy and undiagnosed, I mean the older children, they usually are asymptomatic to start with, and presenting later on with leg discomfort during the exercise. Why? Because the blood flow to the lower limbs is decreased due to the constriction, and they develop headache and epistaxis due to hypertension, because there is constriction at the descending aorta. The blood pressure will be high in the upper part of the body, I mean in the upper limbs and in the head. So they develop headache, epistaxis because of the hypertension, while the lower limbs shows pain and discomfort during exercise. Then, coarctation of aorta depends on the severity of the constriction, and we have two types, infantile type and childhood type. The infantile type presented with feeding difficulties, respiratory problems, and shock. And if undiagnosed and past the infancy, the older children may develop leg discomfort during exercise, headache, and epistaxis. On examination, there is decreased or absent lower extremity pulses بين السبب واضح because of the decreased blood flow to the lower limbs, upper extremity hypertension مثل ما قلنا قبل قليل, and they might be systolic murmur. Any blood which flows across stenotic area produces murmur, and the murmur of coarctation is best heard in the left interscapular area of the back, and between the scapula posteriorly, more toward the left side. Sometimes there are significant collaterals like this because there is constriction of blood and no adequate blood flow to the lower part of the body. Patients develop collaterals from the subclavian artery and axillary artery, which are the intercostal arteries. They become tortuous, dilated, and transport blood from the subclavian artery to the descending aorta. And if such collaterals are present, the patient may show continuous murmur when you hear throughout the chest. So these collaterals are the cause of this continuous murmur. On investigations, ECG, of course, because there is obstruction. And the infantile type, together with the chest X-ray, show features of right ventricular hypertrophy with cardiomegaly. There are details about that, maybe not so important for you, and even pulmonary edema. So in the infantile type, there are features of right ventricular hypertrophy. While in the older children, they may show left ventricular hypertrophy and mild cardiomegaly. Left ventricular hypertrophy opposite to right, and the right ventricular hypertrophy prominent R in V1. While in left ventricular hypertrophy, there is a prominent R in V5 and V6, more than the normal. In each age group, we have normal limits of the R wave. When measured and found more than the normal limit, it is called hypertrophied ventricle, whether right or left. By chest X-ray, in older children, because of these collaterals that I told you about, there might be notching of the ribs like this, as you see. notching يعني محفرة ridge فيها مثل الحفرة صايرة due to the tortuosity of these intercostal arteries which serve as collaterals between the subclavian artery and the descending aorta. By echo, this is the aortic arch, and if there is ductus arteriosus, it could be seen here. And here you see that the vessel has become narrow at this point. It is normal, narrow, normal. So this is the area of the coarctation. And this is seen by a special view called suprasternal view. The aortic arch by echo can be seen by special view. We call it suprasternal view. You can see the aortic arch like that, and if there is narrowing, we can see it, and we can measure the pressure gradient here. Treatment, if it is diagnosed in the infants and they are symptomatic, it means the condition is very severe. And here we have to give prostaglandin E1 infusion to the infant. Why? Because the prostaglandin E1 infusion prevents closure of the ductus arteriosus. And if you remember, when we spoke about the ductus arteriosus, we said that it is useful in the case of severe coarctation of the aorta. Why? Because it provides the blood to the lower part of the body. So if in real life, during the first few days of life, coarctation has become symptomatic and diagnosed, prostaglandin E1 infusion should be given to maintain patency of the ductus and maintain perfusion to the lower part of the body. And after that, during infancy, balloon dilatation of the coarctation by transcatheter method by pediatric cardiologist can be done to dilate it, or if it fails, by surgery, like that. Either surgery or balloon dilatation in the infants. If it diagnosed later on in older children, balloon dilatation again can be used, or balloon dilatation and stenting. We dilate it with balloon and insert a stent inside the vessel to keep it open because it becomes tough tissue and less elastic. So the area of coarctation is difficult to dilate. In order to maintain the patency after dilatation, we insert a stent. The stent, in fact, is loaded over the balloon. We dilate the balloon and then deflate the balloon. So the stent will be dilated and left inside. And after deflation of the balloon, we take it out and the stent will remain in place. And if this fails also, surgical repair is another option. So in infants who are symptomatic, prostaglandin E1 infusion, balloon dilatation, or surgery. Stent is not possible in infants because they will grow and the stent will produce iatrogenic coarctation by the age of 2 or 3 years of life. But in older children, balloon and stenting or surgical repair. Aortic stenosis. This is another type of obstructive lesions, which are acyanotic. In fact, aortic stenosis and pulmonary stenosis, both of them could be valvular, I mean at the level of the valve, subvalvular, below the valve, or supravalvular, above the valve. Aortic stenosis form about 5% of all congenital heart disease. It develops also early in gestation and develops because of the failure of the normal development of the 3 leaflets. This is the aortic valve, which consists of 3 parts. We call it 3 leaflets. This is during closed phase and this is during open phase. During diastole, during systole, 3 leaflets. And this is the abnormal valve. You see, it's thick and doesn't close normally, neither open normally. The opening you see here, it is very large during systole of the normal valve, while it is narrow during in the case of stenosis valve. Sometimes, in the case of aortic stenosis, the valve is not consisting of three leaflets, maybe two leaflets only, two halves, and it's called bicuspid aortic valve. Or even one leaflet, and it's called unicusp aortic valve. Just one cusp and small slit in the side, and here it is called unicusp aortic valve. So the stenosis valve may be tri-leaflet like this one, maybe bicuspid, or maybe even cuspid. Clinical manifestations. In the supravalvular type of aortic stenosis, there is association with a specific syndrome called Williams syndrome by the child. This is characterized by mental retardation and elephant fascias. What are the elephant fascias? Broad forehead, depressed nasal bridge, long upper lip. It's called lung philtrum. And prominent ears, long prominent ears. So the supravalvular aortic stenosis is associated with this syndrome, Williams syndrome, which is characterized by mental retardation and elephant fascias. What are the elephant fascias? Broad forehead, depressed nasal bridge, long philtrum, large ears, and hypercalcemia. Mild to moderate obstructions causing no symptoms. هسه راح نعرف عنها بعد قليل يمتى يعتبر mild to moderate يمتى يعتبر severe. While severe stenosis results in easy fatigability because of the poor perfusion to the tissues, exertion or chest pain because of the poor perfusion to the coronary arteries, and syncope because of the poor perfusion to the brain. Infants with a critical aortic stenosis may present with features of heart failure. Physical findings. First, a through may be filled in the right upper sternal border or in the suprasternal notch. And there might be ejection systolic or called mid-systolic murmur, best here in the right upper sternal border. And this murmur is radiating to the neck, the carotids. I mean, when you put the stethoscope and hear the murmur here, you will hear it in the same intensity in the carotid vessels in the neck. The more the severe the stenosis, the higher the frequency, the higher the intensity, and the longer the murmur. So the severity of the stenosis correlates directly with the length of the murmur, the frequency of the murmur, and the intensity, I mean the grade of the murmur. Sometimes with valvular aortic stenosis, you may hear ejection click, a knocking sound here during opening of the valve. A2, which is the aortic component of the second heart sound, may be decreased in intensity because it doesn't close normally, and even may follow P2. Normally, A2 comes before P2. In the case of severe stenosis, A2 even may follow P2 because of the very long ejection time across the aortic valve. And this is the ejection systolic murmur, or what we call it mid-systolic murmur. In the case of mild, it would be short, while in the case of severe stenosis, it would be long normal. In the case of ECG and chest X-ray investigations, with mild degrees of stenosis, the findings are normal. With moderate left axis deviation, left ventricular hypertrophy. And by chest X-ray, there might be post-stenotic dilatation, because the jet of blood which passes through the stenosed aortic valve may impact the pressure on the walls of the ascending aorta, causing post-stenotic dilatation. And the aortic, no. And this appears on the chest radiographs. Echo is the gold standard for the diagnosis of aortic stenosis. It gives us the morphology of the valve, whether it is thickened or not, unicuspid, bicuspid, tricuspid, its movement, how it moves, the condition of the heart, how is it, and failure, hypertrophy, etc., associated defects. And the main thing, it gives us the pressure gradient across the valve. What is the pressure gradient? During contraction, that is to say systole of the left ventricle, there will be a pressure here. And also there will be pressure here. I mean a pressure before the valve or below the valve, and the pressure after the valve. Normally this pressure is higher than this pressure by about 10 to 15 millimeters mercury. For example, here it is 120 millimeter mercury during systole, and here it is 110 millimeter mercury during systole. So the difference between the two is 10 millimeter mercury during systole. This difference of 10 millimeter mercury is called pressure gradient. So pressure gradient. So the pressure gradient normally is 10, for example, or 15 millimeter mercury. It can be measured by echo, this pressure difference or pressure gradient. In the case of stenosis, because of the flow stenosis, the pressure here will be high and here it will be low. For example, 120, 80 during systole. So the pressure difference is 40. We say the pressure gradient across the aortic valve during systole is 40, or might be 50, or 70, etc. According to this pressure gradient, which can be measured by echo, we classify aortic stenosis into mild, moderate, and severe. If this pressure gradient is less than 40, it is mild. For moderate, it is 40 to 70 millimeter mercury. If more than 70, it is severe aortic stenosis. Treatment of aortic stenosis. For mild, no treatment. For moderate to severe, either balloon dilatation by catheter comes from the arterial side and introduce it into the aortic valve and inflate it to tear the adhesions between the leaflets and open this commissures, and if not successful, by surgery. So we call balloon angioplasty or by surgery. For pulmonary stenosis, which forms also 10% of congenital heart disease, it could be also subvalvular, supravalvular, valvular. But in pulmonary stenosis, we got also branch pulmonary artery stenosis sometimes. In fact, for the aortic stenosis, and the same for the pulmonary stenosis, only the valvular side can be treated by balloon. If it is subvalvular or supravalvular, it should be treated by surgery. And if for the valvular side, if the balloon fails also surgery is needed. So for subvalvular, supravalvular, surgery. For valvular balloon, if fails, also surgery. The same happens with the pulmonary stenosis. There is failure of the normal development of the pulmonary leaflets and insufficient canalization of the peripheral pulmonary arteries. And in this case, the patient develops pulmonary stenosis, either subvalvular, valvular, supravalvular, or branch pulmonary artery stenosis. Clinical manifestations, the same with aortic, mild, no symptoms, moderate and severe, causes exertional dyspnea and easy fatigue. In the newborn infants, they may be cyanotic and even may develop right to left shunting at arterial level through the foramen or valley. The patent foramen or valley may remain open and causes shunting of blood from the right to left if there is severe stenosis, causing very high right pressure. The shunt will be from right to left across the foramen or valley, causing cyanosis, just like cyanotic congenital heart disease. Physical findings, the same as the aortic, through may be felt in the left upper sternal border. Mid systolic or ejection systolic murmur in the left second intercostal space, depending on the severity. In mild, it is short. If it is moderate to severe, it will be long and loud. And also it may radiate to the back. Also, there might be a click, opening a click in the case of valvular pulmonary stenosis. By ECG, now you can conclude that there might be right axis deviation, you see here, reaching each other, lead 3, lead 1. Right ventricular hypertrophy R, prominent R in V1, V2. And also there may be post-stenotic dilatation of the pulmonary artery, seen on chest radiographs. The same as with the aortic stenosis. Echocardiography, the same, can give us the degree of stenosis, the type, subvalvular, valvular, supravalvular, or branch pulmonary artery stenosis, and can give us idea about the condition of the heart and the severity. And the same, mild less than 40, moderate 40 to 70, severe more than 70. Treatment, the same with the aortic, subvalvular, supravalvular needs surgery. Valvular needs balloon. If failed, then surgery. Branch pulmonary artery stenosis has no role of surgery and should be treated by placement of stent, like coarctation, because the surgeons cannot reach these areas, which are inside the lungs. So they are treated by transcatheter method, and we place a stent, like what we did in the case of aorta. هسه خلصت المحاضرة الثانية.